Good morning. I'm Dr. Mohammad Rehan, and today I'll discuss about this antibiotic stewardship program. The objectives of this session is goals of the antibiotic stewardship program. We'll discuss about how to understand the core elements of effective antimicrobial stewardship program, and we'll learn how hospitals can improve antibiotic prescribing. So first of all, what is this antibiotic stewardship program? These are the initiatives dedicated to improving antibiotic use across healthcare settings are commonly referred to as antibiotic stewardship program. It's a coordinated intervention designed to improve and measures the appropriate use of antimicrobial agents by promoting the selection of the optimal antimicrobial drug regime, including dosing, duration of therapy, and route of administration. This program is basically introduced in mid to late 90s as a clinical response to developing rapidly escalating rates of antimicrobial resistance and the realization that up to 50% of the hospital antibiotics prescriptions were unnecessary or suboptimal. What they found that at that time the antibiotics were giving when they were not needed. A wrong antibiotics were selected to treat an infection. Antibiotics were continued when they were no longer necessary, and it was using at wrong doses. And the most important is that broad spectrum agents were using to treat the more susceptible bacteria. The main concept behind this COC program is to use the antibiotics wisely at a right dose to treat a specific infection. The right drug, first of all, the right drug should be chosen at a right dose, at a right time, and for the right duration. And this can only be achieved as a coordinated efforts across the doctors' offices, hospitals, long-term care facilities, and other healthcare settings to ensure that the antibiotics are used only when they are necessary and appropriate. So why this program is important? It is important because of the growing threats of the emergence of the antibiotic resistance bacteria at a pace that outstrips our ability to respond. This means the pipeline of the new antibiotics is dangerously thin. This stewardship program is not optional. It is essential to preserving the effectiveness of the drugs we already have. The benefits of this program for an individual patient is this program will reduce the risk of the side effects, lower the chances of developing the resistant infections, and more targeted and effective treatment outcomes. To the public health, the benefits are it slows down the spread of resistant bacteria across the communities, hospitals, and the borders, so protecting the populations who cannot protect themselves. This program basically works on the guideline that is provided by the JCI and WHOs, and it also involves the monitoring, education, and feedback to help clinicians make it better. So the goals of this program are to help the healthcare professionals make the best informed decision so the patients receive the right antibiotic dose and the duration. It helps people understand the importance of using antibiotics only when they are needed and effective. So limit the unintended consequences of giving such medicines, such as adverse effects or creating antibiotic resistant germs, improve the quality and safety of the patient care, and prevent hospital readmissions. Now, if there is an unnecessary and inappropriate use of the antibiotics, so there must be some consequences, and the most important is the risk of Clostridium difficile infection. The exposure to the antibiotics increases this C. diff infection by at least threefold for at least a month. And up to 85% of the patients with C. diff infection have antibiotic exposure in the 28 days before the infection. The second important is the this antibiotic related adverse effects, and it has been seen that 140,000 ER visits per year and about 6.1% of the hospital admissions were due to the adverse effects of these antibiotics. And the most important is the development of the resistance. So when an individual gets an antibiotic, this increases the patient's chance of becoming colonized or infected with a resistant organism. Administration of an antimicrobial course to a patient exposes approximately 1012 bacteria in that patient to selective pressure, which may alter the intestinal microbiota for as long as a year. And increasing use of the antibiotics in the healthcare settings increase the prevalence of resistant bacteria in the hospitals and the community. The United States Centers for Disease Control and the Prevention, the CDC, estimates that more than 2.8 million infections caused by antimicrobial resistant pathogens occur in the United States, resulting in more than 35,000 deaths. And the rates of multi-drug resistant organisms are also increasing, especially it has been noted that during and after the COVID-19 pandemic. So what is this antimicrobial resistance? It is the ability of the microorganism to stop an antimicrobial from working against it. This results in the failure of the standard treatments, the persistence of the infection, and spread to the others. New resistance mechanisms are emerging nowadays and spreading globally. It also increases the cost of the healthcare with lengthier stays in the hospitals. So JCI antibiotic stewardship standard was incorporated in 2017, April 2017, and it applies to the hospitals, critical access hospitals, and nursing homes. This diagram or the picture demonstrates how this program started. The Joint Commission actually started all these through to provide its standards to the which is restricted to the hospitals and the critical care access hospital, and how it evolves outside the hospital boundaries to involve the ambulatory patients or the outpatients. First of all, in 2017, the Joint Commission started to apply its standards for the hospital and the critical access hospitals and nursing care centers. In 2018, they introduced expert consensus that basically look after at the implementation of these standards. In 2019, they introduced a research study that evaluates the prevalence of the leading practices in the accredited hospitals. In 2020, these standards comes out from the boundaries of these hospitals and the critical access hospitals to involve these outpatients and ambulatory programs. And in 2023, the JCI introduced new and revised the old requirements for the hospital, critical access hospitals, and the programs. So when we try to implement these standards, there are some challenges we have to face. First of all, the absence of the leadership. Second is the availability of a specific antibiogram in the organization, poor enforcement of the regulations, time constraints, lack of interdepartmental coordination, and minimal supporting facilities, and the competition among the doctors. The competition among the doctors means the doctors basically do not follow the standard that is provided by the JCI and the programs. These are core elements of the antibiotic stewardship program. The most important, we'll discuss one by one. So first of all, the leadership support is critical to the success of this stewardship program. Program leader or the leaders who will be responsible for the program outcomes, it should be identified. And some programs are co-led by the physicians and the pharmacists. The key supporters for the program leaders are the hospital administration, clinicians, pharmacists, infection control team, quality improvement staff, laboratory staff, and the nurses. For the drug expertise, we have expert clinical pharmacists that have an expertise in this antibiotic stewardship program. And the clinical pharmacists can assist in identifying the areas for improvement by doing regular audits and the feedbacks, monitoring, and the reporting of the unethical or unnecessary practice. The action includes the implementation of these policies and the guidelines that support the optimal antibiotic use. This requires the development of the organizational specific treatment recommendations, so that whenever any antibiotic is prescribed, there must be a proper dosing, duration, and indication must be documented. And we have to avoid implementing too many policies and interventions simultaneously. These implementation basically prioritize on the needs of the hospitals as defined by the measures of restricted antibiotic use and other tracking and reporting metrics. If intervention requires, it basically divides into the broad intervention, pharmacy-driven, and infection and syndrome specific. In broad terms, the interventions, first of all, the antibiotics timeout. So whenever any antibiotic is prescribed, it prompts a reassessment of the continuing need and the choice of the antibiotics. And we have to review after 24 to 48 hours of the prescription or on the basis of the culture results. The second and the most important part of this intervention is the prior authorization. This this basically restrict the clinicians. So the clinicians cannot order or the administer any restricted antibiotics without the prior authorization of the antibiotic stewardship program expert. So this results in the decreased exposure of the broad spectrum antibiotics and the development of the resistance against them. It helps in cutting the cost, and also it prevents or save the patient from the harmful toxicities or the side effects of the antibiotics. These authorization or the implementations should ensure timely expert review and is conceivable to avoid delay of the therapy. And the most important, the prospective audit and the feedback. Here, the role of the antibiotic surgery program clinical pharmacist who is expert in this program, who has a training of this. The other interventions are the pharmacy driven. So at the pharmacy point of view, whenever any antibiotics is prescribed, its dose optimization and adjustment should be done from the pharmacy side. And there should be some automatic alerts in situations where therapy might be unnecessary, duplicative. Means when we start any antibiotic, sometimes we start two antibiotics that overlap the same bugs. So this has to be seen by the pharmacy. Third, the time-sensitive automatic stop orders and detection and prevention of antibiotic-related drug-drug interactions. So whenever any antibiotic is prescribed, proper tracking and the monitoring of the antibiotic prescription, that which doctor has prescribed, what is the indication, and what is the dose adjustment according to his renal or the liver functions, and what should be the dose, proper dose. And they should also monitor the antibiotic resistance pattern, such as the antibiogram, which is released by the organization. Regular reporting information on the antibiotic use and resistance to doctors, nurses, and relevant staff is very important. Education is a very important part of this program. So we have to educate the clinicians and the patients about the antimicrobial resistance and its optimal use, provide regular updates on the antimicrobial prescription, antibiotic resistance, and infectious disease management. And we have to address both the national and the local issues. And to educate in our system or in our organization, we have to choose a format that is easy to understand, like didactic presentations, posters, flyers, newsletters, or the emails. Retrospectively, we have to review the de-identified cases where the changes in antimicrobial therapy could have been made. The role of the outpatient pharmacist is also very important here, because it serves as a final healthcare provider to see a patient before an antibiotic is dispensed. So they should educate a patient and the parents about the proper antibiotic intake and the potential harms of the antibiotic use, including the antibiotic resistance and the adverse drug events. They can provide the guidance for the symptom relief for common infections, which usually does not require an antibiotic. And they also have to promote the available vaccines. Now we can spread our education by means or by the other means to educate the masses. Like we can use the social media, Twitter, Facebook, Instagram, and the others. CDC also gets a smart move. They provide the brochures and the posters in the waiting areas and the fact sheets regarding the improval of the symptoms without the use of the antibiotics in cases of the viral infections. And the WHO is also involved in the this awareness program. They basically engage means they engage all the stakeholders all together, from the hospital leadership to the public, and they provide a clear and scientific proofs with regards to the misuse or the damages secondary to the antibiotics. And they also empower the clinicians uh, uh, to give them confidence when the antibiotic should be stopped when it is not needed. So JCI updated its standards in 2023 and regularly every year. And it basically places a significant greater emphasis on the organization accountability, data-driven optimization, and clinical integration. So there are certain new things that they focus. First of all, the financial and the IT allocation. The organization must officially dedicate a financial resources to support dedicated ASP staffing and necessary IT or the clinical decision support software. There should be a defined leadership, as we have discussed before. Ideally, physician and a clinical pharmacist with a specialized infectious disease or stewardship training must be a part of this program. There should be a multidisciplinary committee which includes the representatives from the medical staff, pharmacy, infection prevention, and the control, nursing, microbiology, and IT. Again, the implementation is the same that we have discussed before. That this program documents the evidence-based use of the antibiotics in all the departments and services of the hospital. And the second is the pre-authorization is very important, and the prospective review and the feedback of the antibiotic prescription practices is very important. So this program must implement at least two formal evidence-based clinical guidelines for common indications based on the local antibiogram data, formulary options, and the patient population. Common target areas include the community-acquired pneumonia, urinary tract infections, skin and soft tissue infections, C. diff colitis, asymptomatic bacteria, and the use of surgical prophylactic antibiotics. Evaluation and accountability, this is also very important. This program or the JCI is basically focused on this. The program should evaluate the adherence to at least one of the implemented evidence-based guidelines. Adherence metrics can be evaluated on the macro organizational level or dialed down to the individual prescriber level to provide actionable feedback. The program is required to document the evidence-based use of antibiotics across all clinical departments and services within the facility. The competency-based education is very important. So we should have a structured and a mandatory clinical competency rather than a voluntary training session. This includes the hospital must provide structured competency-based education regarding appropriate prescription, antimicrobial resistance, and stewardship protocols. So all the clinicians, pharmacists, and the nurses involved in ordering, dispensing, or administering the antimicrobials. Patient engagement is very important to provide the patient and the family education regarding the safe, appropriate antibiotic use and potential adverse events upon discharge or transition of the care. So these are the new things that JCI and the WHO is more focused on these things. These are the list of the restricted antibiotics like vancomycin, imipenem, meropenem, fourth generation cephalosporins, piperacillin, tazobactam, linezolid, and aminoglycoside antibiotics. Now, the usage of these restricted antibiotics in our hospitals, this is the data of 2025 from January 25 to December 2025. Here we can see that these are the total number of the non-restricted antibiotics usage per patient. This is the one, like in 2025, 1,002 patients were treated with non-restricted antibiotics, and 63 patients were treated with the restricted antibiotics. And this is the percentage of the restricted antibiotic usage. And in our hospital, we are trying to maintain this percentage under 5. But as we have seen, this slightly above because the number of unrestricted antibiotic usages were less in 2025. Here we can see that most of the out of these, meropenem is the mostly used antibiotics, and I have gone through the records. So they say that most of the time these antibiotics were used for the critical patients who are admitted in the ICUs. The second most important is the ertapenem. So we have seen when the patient is having an infection which is non-pseudomonal and it requires a prolonged antibiotic. So we usually switch them to ertapenem. The benefits of this ertapenem, it's cost effective, and second is very convenient to the patient because of the once in a day dosing. If we compared with the data from December 22 to November 23, So here we can see that the number of the usage of the restricted antibiotics were more, and the total antibiotics, total patients that were treated with the restricted antibiotics was 833. And here the total is 659, 57 patients were treated with the restricted antibiotics. So the usage of the restricted antibiotics is decreased as compared to the previous years. So this is the picture or the antidiagram of the culture I have taken just to discuss some things. This is a urine culture isolates of the year 2025. In 2025, 3,042 urine cultures were done, and out of them, 365 were isolates. We can see here that the most common infective organism was the E. coli. It is 35%, and 21% is the ESBL, which is the second most common organism. Third is the Klebsiella, and 5% is the Klebsiella ESBL. So here is something need to understand that E. coli is a gram-negative bacterium whose antibiotic susceptibility profile depends heavily on whether it's a wild type, like the ESBL organism strain, or a healthcare-associated multi-drug resistant variant. In clinical practice, susceptibility is stratified by the site of infection and the local antibiogram patterns, which is provided by the JCI and the organizations or the hospitals. So when any patient acquire infection with the standard community strains or uncomplicated infection, we should give or focus on the oral antibiotics like beta-lactam and beta-lactamase inhibitors like augmentin and fluoroquinolones. In cases of systemic or the deep tissue infection, yeah, we can use in these patients the parenteral agents, and we should initially focus on the cephalosporin, the second, third, and the fourth generation cephalosporins. And on the basis of the cultures, we can switch them to aminoglycosides. And in severe cases, we can use the piperacillin as a victim. While in cases of the ESBL producing strands, the carbapenems are the gold standard choice. So we can start with the meropenem and the imipenem, and on the basis of the cultures, we can de-escalate them after 24 to 48 hours or the 72 hours. Nowadays, some novel beta-lactamase inhibitors are introduced, and of them ceftolozane, tazobactam, and ceftazidime avibactam. These are available. So in cases where there is a carbapenem resistant organisms are available, so we can use them. Like we've discussed here, in some cases when there is a carbapenem resistant enterobacteriaceae or CRE or CPE organisms are detected. So these are the good choices as ceftazidime avibactam and aztreonam avibactam. And in cases where there is a multi-drug resistant and no antibiotic sensitivity is found, then only in those cases we should use this polymyxin and the colistin. This antibiotic should be reserved as a last resort salvage therapies due to the high nephrotoxicity and cardiotoxicity. So in conclusion, the antimicrobial resistance is a global threat, and antibiotic stewardship program is the essential solution. Ensure that the antibiotic stewardship program becomes a strategic goal of our organization. Learn the CDC core elements and apply them in our practice. And question as many aspects of an antimicrobial prescription as possible. Utilize our resources like antibiogram, antimicrobial guidelines, protocols, and the policies, and educate everyone. The more people are aware of the problem, the more people will be available to fix it. And always start the basic antibiotics according to the culture results. Thank you.